Hello, so welcome to the kanski lecture series Cornea part 16, and in this part we are going to discuss about the corneal ectasias. The corneal ectasias, we are going to discuss keratoconus, we are going to discuss pellucid marginal degeneration, and we are going to discuss the keratoglobus. So basically, what is the corneal ectasia? Ectasia means that there is a protrusion of the cornea. From the cornea normal shape, it is a little bit of protruded. So this is called the corneal ectasia. Now let's get started with the keratoconus. So basically keratoconus is a apical thinning of the cornea which causes the protrusion of the cornea like this. Keratoconus is progressive disorder in which the central or a paracentral corneal stromal thinning occurs, accompanied by apical protrusion and irregular astigmatism. So, one of the commonest sign of a keratoconus is that there is an irregular astigmatism. So, what does it mean by irregular astigmatism? Is that the cornea is basically corneal astigmatism is basically mean that the corneal meridians have a different. So this is a cornea, and every meridian, different corneal meridians have a different corneal power, and both of the meridian that have a different power is less than 90 degree to each other. Approximately 50% of the normal fellow eyes will progress to keratoconus within 16 years. Both eyes are affected eventually, at least on topographical imaging in almost all cases. It can be graded by the highest excess of the corneal power on keratometry as mild, moderate, and severe. Mild is less than 48 diopter, moderate is 48 to 54 diopter, and severe is greater than 54 diopter. Most patients do not have any family history, with only 10% of offspring developing keratoconus. Autosomal dominant transmission with incomplete penetrance has been proposed. So basically, we are going to basically keratometry is a K reading. We take this measurement with the different instrument. We can take it from the autograph, or we can take it with the keratometer, manual keratometer. So if the corneal dioptric power is less than 48 diopter, then it is mild keratoconus, and moderate is when the K reading is between 48 to 54 diopter, and severe is when it is greater than 54 diopter. Presentation is commonly during the teens or 20s with features initially only in one eye. Systemic associations include Downs, Ehlers-Danlos, and Marfan syndrome, and osteogenesis imperfecta. Ocular associations include vernal keratoconjunctivitis, blue sclera, arrhythmia, Leber congenital amaurosis, retinitis pigmentosa, as well as persistent eye rubbing from any cause. So basically, this causes by experience. If by experience, you will repeat it so many times that you will know it by heart. So some of the very few commonest causes is constant eye rubbing and allergies. So in case of allergies, you constantly rub the eye and it causes the protrusion of the cornea. And very important is the VKC that is associated with the keratoconus. Other commonest causes are, it can also be hereditary, but it is not very common hereditary problem. Systemic associations are Down, Ehlers, Marfan syndrome, in which there is a collagen formation defect. So you can always say that the cornea is protruded in that case. RP is also a very important cause of the retinitis corneal keratoconus, and as well as Leber congenital amaurosis. It is also a form of an RP, atypical RP. We will discuss in the retina chapter. So diagnosis: unilateral impairment of vision due to progressive myopia and astigmatism. Occasionally, initial presentation is with acute eye drops. Patient usually present for keratoconus will present with an decrease vision, and the vision is a constant change of glasses. The patient is basically myopic, and he will need to change glasses every 6 months or lesser than that if it is rapidly progressing. And for what you can find in the glasses, he or she has a irregular astigmatism, and sometimes it can also present with acute eye drops. So one of the typical features of the signs are, so these are very diagnostic signs, and you have to remember these signs by heart. Basically, direct ophthalmoscopy from distance. So direct ophthalmoscopy from distance of half a meter show a fairly delineated oil droplet reflex. Retinoscopy shows an irregular scissoring reflex. Slit lamp biomicroscopy show very fine vertical deep stromal stress lines, Vox striae, which disappear with the pressure on the globe. Epithelial iron deposits best seen with the cobalt blue filter base around the base of the cone, Flesher ring. Progressive corneal protrusion in a cone configuration with thinning maximal at the apex. So what in this is saying that one is very important sign is a Munson sign. Munson sign is basically when you ask the patient to look down, there will be the apical protrusion of the lower lid. So lower lid will become like, when the cornea looks down, the lower lid also looks like this, V-shaped. So this is a case that a cornea is protruded. Another very important sign is that on a cobalt blue filter, you can see the iron deposits line at the apical. Basically, these are iron deposits that come from the tears, because the tears are constantly pooling at the side of apex. So it causes deposition of the iron, and it is called the Flesher ring. And another very important sign is on the retinoscopy, you can see the scissoring reflex, and on the slit lamp microscopy, you can see the stromal stress line in the stroma, deep stroma, and the descent membrane. So this is called Vox striae. So you can see the figure 7.42 keratoconus A is showing the oil droplet reflex. You can see that giving an oil, when you put an oil in a water, it gives an appearance like that, and it is done by the direct ophthalmoscopy. And next you can see that there are stromal stress line. What happened is that these stress line, when you put the pressure on the globe, it disappear. Next you can see the Flesher ring demonstrated by the cobalt blue light as a blue circle, and CD is showing a typical cone. Bulging of the lower lid in downgaze Munson sign, I told you earlier, acute eye drops, is caused by a rupture in a stretched descent membrane that allows a sudden influx of aqueous into the cornea with accompanying pain, photophobia, and decreased vision. Although the break usually heals within 6 to 10 weeks and the edema clears, a variable amount of the stromal scarring may develop. This sometimes gives improved vision by flattening the cornea. Acute episodes are initially treated with cycloplegia, hypertonic saline ointment, and patching or appendage soft contact lenses. Accelerated resolution has been reported with the intracameral gas injection in the acute stage. So what is acute eye drops? So basically, in a case of a keratoconus, the cornea is protruding like this, and when it is protruding like this, the descent membrane is becoming very stretched, and sometimes it got ruptured. And when the descent membrane got ruptured, it causes the there is no endothelium is not functioning properly. It causes the influx at that area of the cornea, and what it causes the corneal edema of that site. So it takes about 6 to 10 weeks to this break to heal, and often that there is a stromal scarring after that. And when a patient present acutely with such kind of stage, we give them hypertonic saline so that there is no corneal edema, and we can give cycloplegics as well, and a bandage contact lens. Keratometer reading are steep. Steep means that it is on the higher dioptic power side. Corneal topography. So corneal topography is very important investigation to see the diagnosis of the keratoconus, and also see the progression of the keratoconus. Corneal topography, keratography, and various novel corneal profiling technique are highly sensitive for detection and essential in monitoring. Characteristically, astigmatism progresses from symmetrical bow tie pattern through an asymmetrical appearance to an infratemporally displaced steep-sided cone. Sometimes a central nipple cone may develop. Contact lens warpage can sometimes appear similar to cone on topography, but is generally more equate shaped. So basically, not much written about the corneal topography in this keratoconus, although it is very important investigations of the keratoconus. So in this what paragraph, what it is saying that typical characteristic signs of the um, mm, keratoconus on a you can see on a color coded map. You can see you can see a thinning in the paracentral area, or you can see in the infratemporal area as well. And you can also see astigmatism from a symmetrical bow tie pattern. So what are the treatment of the keratoconus? Eye rubbing should be avoided. This is the general symptomatic treatment. Spectacles of the soft contact lenses are generally sufficient. In early cases, if thinning is marked, it may be prudent to consider wearing safety spectacle over the contact lenses. So basically, in case of a keratoconus, you have to treat two things. You have to see if it is a progressive disease or it is a non-progressive disease. If it is a progressive disease, we immediately go for the CXL, because it uh, reduces the uh, progression, CXL. And in a non-progressive cases, or when we have done the CXL, then we go for the visual rehabilitation. We do things to improve vision. So we improve vision in number of ways. So what are the number of ways? You can use the spectacles, we can use the contact lenses, and in even some cases we can go for the keratoplasty as well. Spectacles or soft contact lenses are generally sufficient in early cases. If thinning is marked, it may be prudent to consider wearing safety spectacles over contact lenses. Rigid contact lenses, sometimes scleral, are required to higher degree of astigmatism to provide a regular refracting surface. Corneal collagen cross-linking using a riboflavin drops to photosynthesize the eye, followed by an exposure to the ultraviolet A light, may stabilize or even reverse ectasia, but it is not without adverse effect. It can be combined with a ring segment insertion. CXL is commonly used for progression, has been documented. So basically, I have told you earlier, CXL is a kind of procedure which is basically you remove the epithelium and you stain it with the riboflavin. When it is stained, the stroma is stained with the riboflavin, then we put the UVA light. When the UVA light interact with this, it causes um, the collagen bond formation in the cornea, and it causes the tightening of the cornea. So the cornea becomes a little bit rigid, so it does not lead to progression. And it can also combine with the intrastromal ring segment. Intracorneal ring segment implantation using laser or mechanical channel creation is a relatively safe and typically provide at least a moderate visual improvement, facilitating contact lens tolerance in advanced cases. Keratoplasty, either penetrating or deep anterior lamellar keratoplasty, may be necessary in patient with a severe disease. A history of hydrops is a contraindication to DOLT due to the presence of a descending membrane discontinuity. Outcome may be compromised by regular astigmatism and by anisotropia, necessitating contact lens correction for optimal acuity. LASIK is contraindicated. Patients should be screened for keratoconus prior to corneal refractive surgery. So basically, corneal segment rings are basically, in the case of a corneal keratoconus, the cornea is like this. So what happened is we place the segments in the uh, in an arcuate pattern here in the periphery. What causes that? It causes the flattening of the central cornea. When the central cornea becomes flattened, it causes the reduce in the myopia. So in a case of a keratoplasty, we do, if a corneal descent membrane is intact, we do a deep anterior lamellar keratoplasty. Why? Because the descent membrane is intact, we only remove the stroma and we put the, if the descent membrane is intact, we place the donor cornea on the intact descent membrane of the patient. But acute eye drops, because there is a rupture of the descent membrane, we do not do in DALK. Acute eye drops, A is showing the Munson sign with localized eye drop, B is showing the localized corneal edema nipple cone, C is showing the severe diffuse edema, D is showing the late scarring. Now next is a pellucid marginal degeneration. So basically it is also the thinning of the cornea, but in this case we have a thinning of the cornea in the inferior side of the cornea. Like if a cornea is divided into a clockwise pattern like 12 o'clock to 6 o'clock, then you can say that from 4 o'clock to 8 o'clock the cornea is somehow thinned out. So this is a characteristic of the pellucid marginal degeneration, that the cornea is thin in the inferior side. And what defect you can see in the corneal topography is because there is a there is a thinning in that area, and there is a, and you can see the band shape defect in a case of a corneal topography. Pellucid marginal degeneration is a rare progressive peripheral corneal thinning disorder, typically involving the inferior cornea in both eyes. Presentation is usually in adulthood. Slowly progressive diagnosis is symptoms: slowly progressive blurring due to astigmatism. Sign is bilateral, slowly progressive crescent 1 to 2 mm band of inferior corneal thinning extending from 4 to 8 o'clock, 1 mm from the limbus. The epithelium is intact and the cornea above the thin area show ectasia and appears flattened. In contrast to keratoconus, flessuring and Vogt striae do not occur and acute eye drops is rare. Corneal topography shows a butterfly pattern with severe astigmatism and diffuse steepening of the inferior cornea. So what is the pattern in the case of a pellucid marginal degeneration? You can say a butterfly pattern and a diffuse steepening of the inferior cornea. So you can see figure 7.44 is showing the corneal topography, showing the severe keratoconus in the right eye and the early paracentral cone in the left. So you can see the red colors showing the thinning and steepening effect. So you can see in this case it is paracentral, and it is in this case is also central or paracentral. And figure 7.45 showing us the intracorneal ring segment to flatten the central cornea. Now let's discuss the chapter 7.46, pellucid marginal degeneration. B is showing the topography, showing severe astigmatism and diffuse steepening of the inferior cornea. So inferior 4 to 8 o'clock of the cornea is diffusely steepened. Treatment: early cases are management with spectacles and contact lenses. Surgical options, none of which is ideal in patient intolerant to contact lens, include large eccentric penetrating keratoplasty, thermocauterization, crescenteric lamellar keratoplasty, wedge resection of the diseased tissue, epikeratoplasty, and intracorneal ring segment implantation. Result of collagen cross-linking are encouraging. So basically we treat the PMD with spectacles and contact lens. We can do the eccentric grafting, but basically the eccentric grafting is usually a very risky procedure because there is a lot of chance of failure in the case of the eccentric graft. And we can also do different corneal procedures on this as well. We can do intracorneal ring segment, we can do CXL, and we can also do the wedge resection of the diseased tissue, or we can do crescenteric lamellar keratoplasty. Keratoglobus. So what is a keratoglobus? So in case of a keratoconus and pellucid marginal degeneration, there is a particular area of the cornea that is being protruded. And in case of keratoglobus, whole of the cornea is being protruded. You can see the whole of the cornea is becoming protruded from superior to inferior, from horizontal side. Keratoglobus is extremely rare condition that can be present at birth when differential diagnosis is from congenital glaucoma and megalocornea, and association may be present or acquired. With onset in adulthood, in contrast to keratoconus, the cornea develops globular rather than conical ectasia and is associated with generalized corneal thinning. Acute hydrops is rare, but the cornea is more prone to rupture or on relatively mild trauma. Corneal topography show a generalized steepening. Surgery is difficult and contact lens wear is often unsatisfactory. Intrastromal ring segment and corneal cross-linking may have utility. Special care may be taken to protect the eye from the trauma. So you can see that A is showing a keratoglobus, B is showing the Munson sign. In the keratoglobus, you can see whole of the cornea is being protruded, and in case of the keratoglobus, you on a corneal topography you will see a diffuse corneal thinning and diffuse corneal steepening of the whole of the cornea. So that's it for the cornea part 16. We will see you in the next